A very good morning. A warm welcome to all participants from Malaysia, the SEAMEO Network and affiliated countries to IMR-SEAMEO Webinar Series 2022. We appreciate you taking time off your busy schedules to join us today. As we know, the theme of our webinar session today is Endocrine and Metabolic, Insights into Preclinical and Clinical Perspectives. And our presenters today are from the Institute for Medical Research. I'm Dr. Ezarul Faradianna, of the Food Nutrition Unit, IMR. I'll be saying your moderator today. This session is to share a latest cycle research and research arm. I hope this webinar should be a good platform for us to establish our network and link research collaborations. Before we begin our presentation, allow an announcement of housekeeping from the research. We will take any questions during the presentation, but people report their questions using the link that will be shared in the initial email you have now. Answers will be conducted at the end of the presentation. And finally, let's look over for those who receive an certificate attendance. You find the link in the box of the webinar. Ladies and gentlemen, today's webinar session is seen preclinical and clinical studies carried in a sense to have users. The platform introduced today. Our speaker is Dr. Ezarul Faradianna, Lokman. He is research from Endocrine and Metabolic IMR. She is in decline.
Dr. Farah is best known for her diabetic animal models, focusing on mechanisms of insulin release and sensitivity related to herbal plants or compounds. She has also published several diabetes-related scientific articles. For today, Dr. Farah will be sharing her topic on preclinical research titled Experimental Studies for Drug Discovery via Targeted Pancreatic Islet Channels in Animal Model of Diabetes. Dr. Farah, the screen is yours.
Okay, thank you Dr. Bimala for the introduction. So Assalamualaikum and salam sejahtera and good morning everyone. I'm Dr. Farah. I'm research officer from Endocrine and Metabolic Unit, and my today's presentation is on experimental studies for drug discovery via targeted pancreatic islet channels in animal model of diabetes. So based on National Health Mobility Survey conducted in 2019, number of people with diabetes has increased from 13.5% in 2015 to 18.3% in 2019, with 1 to 5 adults above age 18 years old have been diagnosed with diabetes. So diabetes is characterized by both an impaired insulin secretion and insulin resistance. So it occurs when the insulin fails to regulate the glucose level due to the decrease of insulin signaling in the target tissue, such as the muscle, liver, and the adipocyte. And this will lead to the increase of glucose production from the liver and decrease of glucose uptake in the muscle and adipocyte tissue, and also the increase of glucose absorption in the intestine. And all of these will lead to hyperglycemia. So the current treatment for type 2 diabetes include insulin and other oral hypoglycemic agents such as biguanide, sulfonylureas, and alpha-glucosidase inhibitors. However, due to several unwanted side effects, search for more effective drug from plant origin continues, and herbal medicine has always been suggested since ancient time to be able to treat several diseases including diabetes, and several studies have shown that medicinal plants exert its anti-diabetic properties either by improving insulin secretion or improving insulin sensitivity in the target tissue. So the objective of this presentation is to provide knowledge on preclinical experimental techniques in pancreatic islets using rodent. Now I'm going to talk about the animal model of diabetes, and over the years animal models have been used for the study of diabetes depending on the research questions. And similar to human, rodents also develop diabetes due to beta cell islet dysfunction and also insulin resistance. And there are several animal models of diabetes which can be used for the diabetes studies, such as the spontaneously or genetically derived rat, the diet nutrition induced, the chemical induced, or the transgenic knockout models. However, there are still some advantages and disadvantages using the animal model. Like, for example, the type of animal model used, age, gender, or treatment duration may actually influence with the glucose, insulin, and also the hormone levels. And also, for example, the use of the spontaneously genetically derived rat with the homogeneous genetic background and the well-controlled condition is actually better as compared to, like for example, the chemical-induced rat with either alloxan or streptozotocin chemical, which may result in the different degrees of beta cell islet destruction and also may cause toxicity to the vital organs. And also, one has also need to remember that treatment that shows positive results in rodents may not necessarily show similar effect when being tested in human. However, regardless of this, the use of preclinical data obtained is very important to ensure that it can and can be justified to be translated into clinical trials. In endocrine and metabolic research, there are several preclinical studies can be done to understand the anti-diabetic effect of certain test items. It can be divided into the in vivo, the ex vivo, and also the in vitro experiment. For the in vivo study, you can perform the oral glucose tolerance test to understand how well your body utilize the glucose, and also you may also perform the insulin tolerance test to understand how sensitive your tissues toward the effect of insulin, and also you may perform the pyruvate tolerance test to understand the gluconeogenesis process, which is the conversion from the pyruvate to the glucose. And for the ex vivo study, you may use tissues from rodents, different tissues from rodent. As an example, the pancreatic islet, you may perform the isolation of pancreatic islet, where you could actually measure the islet glucose stimulated insulin release, the mechanism of insulin release, and also the kinetic of insulin secretion. Apart from that, you may perform the isolation and the perfusion of rat liver for determination of the hepatic glucose output and also the hepatic glycogen content. And from the fat tissue, you may perform the lipolysis experiment to measure the free fatty acid, and also you may measure the glucose utilization in the specific tissue, like for example the muscle, the liver, and also the adipocyte tissue. And there are so many references which you can refer to. For the in vitro study also, other than tissue and islet sample, you may use the cell lines like from rodents, and the most commonly used cell lines are like RIND, HEAT, MIN, and others. And also recently in 2011, actually they discovered the new cell lines from human, which is called the Endo-C beta H cell lines. And then in the subsequent years, they discovered more cell line from human. And also it is interesting also to study about the digestive system by measuring the alpha glucosidase inhibitory activity, the alpha amylase, and also the DPP4 inhibitory activity. So for this presentation, I'm only going to focus on the ex vivo methods, which is the isolation of the pancreatic islets and the mechanism of insulin release. The majority of the pancreatic islets is actually composed of the beta cell, which is known for the insulin secreting function, and so it actually helps reduce the glucose level in blood, and it takes up to 85% of the pancreatic islet. This is followed by the alpha cells, which is important for the glucagon secretion, and it actually helps to increase the glucose in blood. And there are other remaining cells like delta, alpha, delta, gamma, and also epsilon. And also for delta, it actually secretes somatostatin, which is very important to inhibit the secretion of both insulin and glucagon. Gamma cell, which is important for the pancreatic polypeptide to maintain the energy balance, and also the epsilon for the production of ghrelin, which is important for the appetite control. So in summary, the interactions of the cells are very important to maintain the glucose homeostasis in blood. Without all these cells, maybe you would have chaotic blood glucose level. And then also, actually there are about 1,000 of islets can be obtained from rodents. Like in rats, it's probably 3,000 islets, or you can get it lesser in mice. And the islets of rodents actually show similar characteristic to human, which makes it ideal for the study of diabetes. Okay, now I'm going to show you how the insulin is being secreted from the islets. So in principle, the mechanism of insulin secretion is actually dependent on the KATP channel. So when the glucose is elevated in the blood, it will enter the islets through the GLUT2 transporter in rats, in rodents, whereas it is GLUT1 transporter in human. And it will be metabolized through the glycolysis and also the citric acid cycle, which will lead to the increase of the ATP and ADP ratio, and which in turn will lead to the closure of the KATP channel. This will lead to the membrane depolarization, where it will lead to the opening of the voltage sensitive L-type calcium membrane channel, which will force the calcium to enter the islet cells. And there are also other proteins involved, such as the protein kinase A, protein kinase C, and also the G protein, which eventually lead to the exocytosis of the insulin release. To further understand on which channel does your test item exert its effect on, you need to use several inhibitors to block the specific channels. Like for example, the KATP channel, you may use diazoxide, whereas for voltage sensitive L-type calcium channel membrane, you can use nifedipine and H89 L-carboxyl C to block the protein kinase C and protein kinase A respectively, followed by the use of pertussis toxin to block the G protein. So by understanding the mechanism of insulin release, you may be able to understand on which channel does your test item show its effect on. Okay, so now I'm going to show you how the collagenase digestion method is being carried out in rat. Okay, first, the rodents can be euthanized in a carbon dioxide chamber. In in the case of rat, you may perform the collagenase digestion method by inserting the collagenase enhanced buffer through the duct, and then it be processed with hem buffer, Histopac 119. And there are several steps involved. Whereas for mice, you can actually just take out the pancreatic islet since the size is small, and then it can be further processed using the incubator shaker at 37 degrees. And then also you can just proceed with the washing process with hang buffer. And so the islets obtained actually it can be observed under the microscope. You have to separate the islets from other tissues. So this is the examples of the islets with other external tissues, and this is the example of the islet which has been isolated from other tissues. And this is usually what you get. The islets is inside, you cannot see it from here. However, the islets obtained, you need to incubate it overnight in incubator at 37 degrees, supplied with carbon dioxide incubator. It is incubated in RPMI, and usually for each experiment, we will need about 3 islets. And it has to be incubated in low and high glucose in the KRB buffer, and then depending on your experiments, either you want to study the insulin secretion or you want to see the mechanism of insulin release on the specific channel, you may add your test item compound. And of course, for the insulin measurement, you need to use the ELISA. Since like I mentioned just now, the islets is composed of different cells other than beta cell. Beta cell is quite known for the insulin secreting activity. However, there are other cells like alpha, delta, gamma. You can actually further study using the incubation in calcium-free medium, and also mechanical and or enzymatic dispersal experiment, which personally I haven't done this before. It's also if you want to study the channels on the alpha, delta, gamma, you may use the patch clamping experiment. And also this one I haven't done this, but I can just give some suggestion on what can be done with other cells. Okay, here is the summary of my presentation. The take-home message is that by understanding the mechanism that regulate insulin secretion and also the beta cell regenerative properties, this will allow the development of the potential therapies for diabetes. And before I end my presentation, of course, I would like to thank SEAMEO for giving me the opportunity to deliver this topic, and also for those who have supported my provided funding for my study and project, which is the Ministry of Health, National Institute of Health, IMR, and also my collaborator, which is the Crown Research Studian Berhad, and all of my NMR-SEAMEO members, my lab technologies for their lab animal support. Okay, so these are the references used for my presentation, and with that, thank you, and I will pass back to Dr. Bimala. Thank you.
Thank you, Dr. Farah. If you have any question, kindly submit your questions through the link provided in the chat box. Next, I would like to introduce our second speaker for today, Dr. Shazana Rifham binti Abdullah. Dr. Shazana is a public health medicine specialist of endocrine at Endocrine Metabolic since 2019. She holds a medical degree from University Science Malaysia, while her Master of Public Health and Doctorate in Public Health from University Malaya. Her research interests mainly focus on obesity, childhood obesity, non-communicable diseases. Without further delay, I would like to invite Dr. Shazana to give her talk on her clinical study titled Cardiometabolic and Anthropometric Outcomes of Intermittent Fasting Among Overweight and Obese Civil Servants in Malaysia. Over to you, Dr. Shazana.
Assalamualaikum warahmatullahi wabarakatuh and a very good morning to all. Thank you Dr. Bimala for the introduction. I'm Shazana Rifham binti Abdullah. Today I will present the methodology and protocol of my research project entitled Cardiometabolic and Anthropometric Outcomes of Intermittent Fasting Among Overweight and Obese Civil Servants in Malaysia. So this is the outline of my presentation today. The epidemic of overweight and obesity has become one of the most alarming public health threats nowadays. Although it is largely preventable, the worldwide prevalence of obesity nearly tripled between 1975 and 2016. In 2016, more than 1.9 billion adults were overweight and 650 million were obese. And if this current trend continues, it is estimated that 2.7 billion and over 1 billion adults will be either overweight or obese by 2025 respectively. In Malaysia, the National Health and Mobility Survey, NHMS 2019, have reported that 50.1% adults in Malaysia were either overweight or obese, which is increasing compared to the data that was reported by the NHMS 2011 and 2015. Obesity is a very complex condition. If left untreated, it will cause a lot of poor health outcomes. Despite the increase of non-communicable diseases such as cardiovascular disease, diabetes, and certain cancers, a growing literature has demonstrated a positive relationship between obesity and various mental health issues such as poor quality of life and depression. Since obesity occurs due to a positive energy balance of the body, the strategies for preventing and treating obesity mainly focus on dietary modification and treating and increasing physical activity. One form of calorie restriction is intermittent fasting, or we call it IF. It is a various eating diet plan that cycle between a period of fasting and non-fasting states over a defined period to create a negative energy balance, thus promoting weight loss. In countries with predominantly Muslims like in Malaysia, the practice of dry fast during Ramadan and voluntary 2 days per week fasting like in Monday and Thursday are widely carried out. So what is the difference between dry fast and wet fast? So wet fasting, or some might call water fast, is a fasting in which no food or fluid intake will allow except for plain water and 0-calorie beverages, while the dry fasting is a complete fasting without any food, without any fluid intake allowed. So, although the effect of wet fasting have been well documented, the benefits of dry IF, except for Ramadan fasting among Muslims, is not clearly indicated in previous studies, especially in Malaysia. So, another practical method of calorie restriction is portion control. When we control the portion size, at the same time we control the calorie intake. So, this portion control method had been widely practiced all around the world, using a different portion division based on the culture and also the eating habits of the countries. So in Malaysia, we have the Malaysian healthy plate, or quarter half concept. Malaysian healthy plate created to translate the messages in the Malaysia Dietary Guideline 2010 and the Malaysia Food Pyramid 2010. It is a visual tool that emphasizes the quarter half concept that helps ensure the intake of food is within the recommended guideline. So specifically, it is a single meal guide that divides the plates into a quarter plates of grains and grain products, a quarter plate of fish, poultry, meat and eggs, and a half plate of fruits and vegetables. So similarly, although this policy has been widely practiced in Malaysia since 2010, but the effectiveness in promoting the weight loss and improving the cardiometabolic risk is still not well documented. So based on this foundation, we established this study with the aims to, first, to determine the cardiometabolic, anthropometric, dietary intake and quality of life changes among overweight and obese civil servants following combined intermittent fasting and healthy plate intervention And the second aim is to explore the participants' experiences throughout the study. This is a quasi-experimental study applying mixed study method, which involve quantitative method and qualitative method. Quantitative method involve allocating participants into two intervention arms, which are IFHP, intermittent fasting healthy plate, the combined group, and healthy plate HP group. And then we measure the outcomes at baseline, month 3, and also month 6. Whereas the qualitative part in the study plays an important role in the screening of the participant and exploring the experience of the participants via readiness to participate screening and focus group discussion. So this qualitative part in our study was led by Dr. Zabri Johari from the Institute of Health Behavioral Research. So the inclusion criteria of our participant in this study were workers aged 19 to 59 years with body mass index of 23 kg per meter square or more, meaning that either overweight or obese, ready to participate in the intervention, assessed through the readiness to participate screening, and provide the informed consent. The participant in our study was allocated into the intervention group based on the their place of working at that time during the recruitment phase, meaning that participants who were stationed in the institute, in the National Institute of Health here in Siti Alam, were allocated in IFHP group, whereas those who work in Institute for Medical Research Jalan Pahang and Institute Latihan Kementerian Kesihatan Malaysia, which was also in Jalan Pahang, was allocated in HP group or healthy plate group. So, for dietary protocol for intermittent fasting, it involved dry fasting from dawn to dusk, which was approximately 13 hours, and participants were encouraged to have a meal before dawn. It up to them whether they want to have a complete meal or simple meal. And during the fasting period, no food or drink was allowed at all, and the fasting adherence was recorded by our research assistant twice weekly, whether they fast that week, only fast one day, or they managed to fasting for 2 days that week. For Malaysian Healthy Plate, all the participants were advised to practice Healthy Plate for all the 3 main meals per day. However, only the practice of at least one Healthy Plate meal that fulfilled the requirement of Healthy Plate, the quarter half concept, was accounted as the minimum requirement for adherence to the dietary protocol. So they need to send the meal picture to our research assistant every day. Okay. So this is monitored by the daily record of food intake picture. So in summary, participants in the IFHP group need to dry fast from dawn to dusk for 2 days per week on Monday and Thursday, and practice of the healthy plate concept for the rest of the week, and do not need to follow the HP diet during the fasting day, meaning that they need to fast 2 days per week, and another 5 days they need to practice this healthy plate plan. Whereas for participant in healthy plate group, they need to practice the HP concept every day, 7 days per week. Okay, this study divided into 2 phases, recruitment phase and also intervention phase. The recruitment of the participant in the study was conducted in 2 stages, health screening and also readiness to participate screening. An invitation was sent through Google form, through email and also phone calls to invite them to participate in our study. So those who were interested then were screened for the inclusion and exclusion criteria, and of course their BMI, and those who were eligible were screened again in the readiness to participate screening, which was conducted through the face-to-face interview. And during that screening, their motivation, their willingness to commit and their enthusiasm was assessed. So only those who are ready to commit were invited to join our study. So the overall intervention phase of this study was 6 months, 3 months in supervised phase and another 3 months in unsupervised phase. And focus group discussion was conducted at the end of the 6 months, the month 6 I mean. So during the supervised phase, the participant start the intervention, using the diet protocol based on the assigned group. Okay, so the participant in IFHP group was sent a reminder to fast on the eve of the fasting day, and then participants from both groups need to send a meal picture, like I said just now, to send a meal picture of their meal or their plate once per day that fulfill the requirement of healthy plate concept. Otherwise, there's no fasting reminder, no picture need to be sent during the unsupervised phase. So the data collection of this study was conducted at 3 points during the 6-month period. The baseline data collection was conducted before the supervised phase, month 3 data collection after the supervised phase, and month 6 data collection after the unsupervised phase. So during the data collection, the participant need to answer a self-administered questionnaire, and at the same time, anthropometric measurement and biochemical sample were taken. Okay, these are the outcome variables of our study. So we collected data on demographic, anthropometric, quality of life, physical activity, dietary intake, and also biochemical data. The quality of life in this study was measured by obesity and weight loss quality of life instrument, physical activity by the short form of IPAC, International Physical Activity Questionnaire, and food frequency questionnaire was used to measure the dietary intake. For biochemical testing, we took blood to measure for fasting blood glucose, 2 hour postprandial blood glucose, HbA1c, fasting lipid profile, and fasting insulin. So all this data were collected at all time points of data collection except for demographic data, which was only collected during the baseline. So for preliminary result, okay, the analysis of this study, the data analysis of this study is still ongoing. So for preliminary result, I will only present the participant flow chart and also the basic characteristic of our participant during the baseline. So a total of 302 volunteers interested to join our study. However, after underwent 2 stages of screening that I explained before, only 177 participants were eligible and recruited in this study. 91 in the IFHP group and another 86 in the HP group. So during the supervised intervention phase, 28 of the participants withdrew, and another 27 withdrew during the unsupervised phase. So the reason for withdrawals including pregnancy, they were diagnosed to have hypertension, diabetes, or hyperlipidemia that needed them to be on medication, which was also diagnosed or we screened during our data collection. And other than that, they feel unable to commit to the intervention, and some of them were transferred to new workplace. So in the end, there were 63 and 59 participants who completed the study from IFHP and HP group respectively. So this table showed the basic characteristic of our participant during baseline, comparing the both group. The mean age of the participant is 34.4 years. Majority of our participants were Malay, female, and has diploma and degree as the highest education status. As we can see here, there is a significant difference in proportion of job category between the two groups during baseline. This is most probably due to the departmental unit that's stationed in Jalan Pahang is being diagnostic based. So that's why there is a higher proportion of MLT in HP group compared to IFHP group. Otherwise, there's no significant difference in proportion of smoking history and background illnesses between the participant in both intervention group. This slide shows the comparison of anthropometric measurement. As we can see, the BMI of participants in IFHP group were slightly higher compared to those in HP group. However, the difference is not statistically significant. And overall, there is no significant difference in the majority of the socio-demographic characteristic and anthropometric measurement between our participants in both groups during the baseline. So for strength and limitation, a strength of our study is that it apply both quantitative and qualitative methods. So this mixed method allow us to measure the effectiveness of the intervention and explore their experiences while practicing the intervention at the same time. So this integrated framework is very important because it gives us more understanding in the experiences or what challenges that they face while they doing the intervention, so that it can be improvised, it can be improved in the future program. So other strength of our study is that it allows more generalization of the findings because we involve a wider range of age and both sex for our participants. And the main limitations of our study is that the effect of movement control or the MCO due to the COVID-19 pandemic on intervention compliance and weight management. So the implementation of MCOs and work from home may limit their physical activity, expose them to unhealthy eating, can reduce their motivation toward weight management, and also may affect their control over food intake. So as I said just now, the data analysis for this study is not yet completed, and the compliance data also not yet the data analysis of the compliance data also not yet being done. So we hope despite of this obstacles and limitation, we still could get a positive result for our study. So in conclusion, with the increase of prevalence of overweight and obesity worldwide, a weight loss method that is not only effective but most importantly practical and easy to comply is needed. We established this study to determine the effectiveness of combined IFHP and HP in improvement of the anthropometric and cardiometabolic outcomes among overweight and obese civil servants. So this study findings and the in-depth explanation of the findings may perhaps contribute to the development of more effective and feasible obesity program prevention method and provide new insights that will stimulate new research questions in the future. So this is the references that I use in this study. So before I end this presentation, I would like to take this opportunity to thank all my team members, the collaborators and the MLTs for their hard work and commitment, and of course most importantly to the participant of this study for their support and also support and assistance study. So that's all from me. Thank you very much.
Thank you, Dr. Shazana. So now we will move to question and answer session. Please do not hesitate to send us your questions. Nevertheless, should the time does not allow us to address all the posted questions, our speakers will try their best to answer all relevant questions through email. So now, I think while we are waiting for the question from the audience, allow me to ask few questions to the speaker. Maybe we can start with Dr. Farah.
Yeah, Dr. Farah.
Today, most of your, your presentation is basically on the techniques. Yeah. So for the ex vivo, so you are actually focusing on your ex vivo. So I would like to ask, your isolation technique of pancreatic islets seems to be quite laborious. Yeah. So and I think to a certain extent, I think you need the skill to actually isolate. I mean, like you need to cannulate and insert the collagenous inside the pancreas. And so like maybe like researcher like me, I will have difficulty to learn the techniques and so on. So do you cater services in your lab, or how can I work with you if I want to do this technique?
Okay, so you mean for the ex vivo study
Yeah,
involving
pancreatic isolation? Yes.
Isolation,
Yeah.
right? Okay, so actually, so far we do not provide any lab service related to the idle isolation using rodents. However, if there are some demands, maybe we can consider to provide some training program to educate researchers on how to perform the specific technique. And also, however, although we do not provide any lab service, we welcome any researchers who are interested and who are willing to collaborate with us. I think I answered the question.
Yeah. Thank you, Dr. Farah. So anyone who's interested in these techniques maybe can contact Dr. Farah. So now I think we have few questions here. Our first question is to Dr. Shazana. Yeah. How do you exclude participants from this study? So I realized just now that I think you didn't include the exclusion criteria. Maybe you can share us how do you exclude your participants?
Okay, yes, thank you for the question. Yes, I did not include the exclusion criteria in the presentation due to time limitation. But yes, we do have exclusion criteria of this study, of the participant of this study. We apply this exclusion criteria in two stages: the screening during the screening process, and another one during the intervention. Okay, so we excluded participant who first. If this is during the recruitment phase, if they have any recent involvement in any weight loss program, because we don't want to mask the effect of our intervention if they have any improvement of the the outcomes. And the second one is, I'm not mistaken, if they have eating disorder problem from the start, so we exclude them from the screening process. And the third one is, yes, this is very important, we excluded participants that have been diagnosed to have hypertension, diabetes, or any non-communicable disease like hyperlipidemia that needed them to be on medication. Why? Because there's two reasons behind this criteria. The first one is because when they are on medication, any changes in their outcomes, for example, if they are diagnosed to have diabetes mellitus and they are given the glucose lowering agent, so any changes in the glucose blood sugar, we don't know whether the changes is due to the medication itself or because of the effectiveness of our intervention. The second reason is that study have shown that many medications such as glucose lowering agent like metformin can interfere with the weight management, like it can cause weight loss, and insulin also have been proven to can be cause weight gain. So we want to reduce this confounding effect as much as possible. And then another exclusion criteria is that if they're pregnant, of course, if they're pregnant during the intervention, we will exclude them. And then I think lastly, if they have a lack of ability to understand or to able to perform the intervention independently. So if I'm not mistaken, that's all. Yes. Thank you.
Thank you, Dr. Shazana. So we will look for the second question. Okay. Second question will be for Dr. Farah. So, Dr. Farah, your expertise is on medicinal plants and anti-diabetic effect using rodents, right? So, can I know so far what kind of medicinal plants have you investigated?
Okay, thank you, Dr. Vimala, for the question. So, over the past 10 or 12 years, I have studied several medicinal plants. And actually together with my team member from Karolinska Institute, led by my professor Claes-Göran Ostensen, we have studied the anti-diabetic effect of Gynospora pentaphyllum and also Tinospora crispa, and maybe I can just talk briefly about the findings. Like we found that the medicinal plants showed some anti-diabetic properties by improving insulin secretion and improving insulin sensitivity in the specific tissues. And actually you can refer to my previous publication, and also when I returned back to Malaysia, I did an experiment together with Dr. Hussein from Toxicology Unit at HMRC, where we studied the effect of orthosiphon staminus, which means tai kucing, and we tested the anti-diabetic properties in the pregnant rats, and we discovered also the misai kucing has some glucose lowering effects. I think and right now I'm working with the Crown Research Sinan Berhad to study the anti-diabetic effect in sago plant. Okay, I think that's all, Dr. Vimal.
Thank you, Dr. Farah. So our next question will be for Dr. Shazana. Dr. Shazana, okay, this study was a quasi-experimental study design. there's a question why you did not randomize the allocation of participant into the intervention group.
Okay, thanks Dr. Vimala, and thanks for those who is asking. This is a very important question because it's quite popular during our submission to journal also. One of the reviewer asked us this similar question. So yes, we agree that the randomization allocation of participant into intervention group is like more superior, will increase the credibility of the study, and most importantly will reduce bias. Yes, that's the most important thing, reduce bias. But we in this study, since both of our intervention were conducted in NIH here in National Institute of Health, so we need to non-randomize. We need to perform a non-randomized allocation of the study participant to prevent the contamination bias. So what is contamination bias? Contamination bias occur when a member of one group in a trial exposed to the intervention of what intervention that is meant to another group. So it will reduce all the real it will reduce the real difference that happen if there are any difference in the outcomes. So after we discuss with the epidemiologists and statistician who are also one of our collaborators, so we decided to perform a non-randomized allocation of our participant based on the place of working, whether they are in the Setia Alam or in the Jalan Pahang, to avoid this problem contamination bias. So I think that's all.
Okay, thank you, Dr. Shazana. There's a question also asking whether is 3 months duration is enough to see cardiometabolic changes following this intervention?
Dr. Shazana, yeah.
Can you repeat that question?
Yeah, I think they are actually querying about your 3 months duration. Is this enough to see cardiometabolic changes following the intervention?
Okay, thanks for the question. Yes, that's not the most ideal. To see the significant changes in cardiometabolic parameters for blood parameters, it's usually need more than 3 months. However, I think we still can see changes in the anthropometric measurement, yes, but provided they are compliant to the intervention. So actually, in the beginning of this planning of this study, we plan to conduct this study in 12 months. Actually, 6 months in supervised phase, another 6 months in unsupervised phase. But due to several factors and reasons such as budgeting, and also yes, of course, the pandemic, the COVID-19 pandemic at that time, we only managed to do it in 6 months. Because frankly, if we do the intervention more than that, I think we will face more withdrawals from the participant, because conducting primary research diet modification research during this pandemic is very challenging. In fact, during one session of data collection, I think the second session of data collection in April 2021, at that time we just have second wave of pandemic COVID-19. So at that time, one of our study members infected by COVID-19. So the team members and the participant need to be quarantined, but alhamdulillah there's no transmission happen because we really comply to strict SOP while doing this data collection. But because of that, about 2 or 3 participants were withdrew from our study because they're afraid to come during the data collection. So after that, also the participant, I think lots of participants withdrew because they're unable to commit with the dietary intervention, because they think when they are at home it's very difficult to control their food intakes, to apply the quarter half concept, and also to do the intermittent fasting. So to answer the question, yes, it's not the most ideal way, but that's the best that we can do at that time, taking into account the limitation and challenges that we face during that time. So I hope that answered the question.
Thank you, Dr. Shazana. I think we still have time to take 2-3 more questions. So next question will be for Dr. Farah. So I think this question is from Dr. Hussein. So what is the best diabetic animal model should be selected to study diabetes complications such as nephropathy, neuropathy, and retinopathy, Dr. Farah?
Okay. Thank you for the question, Dr. Hussein. What is the best diabetic animal model should be used for the study of complication? Actually, it depends on your research questions, but in overall, I can suggest you to use the spontaneously diabetic tori rat SDT for the lean model, or you may use SDT, the fatty rat, for the obese type, because this rat represents the diabetic complications like you mentioned here, like nephropathy, neuropathy, and it also developed hyperglycemia at the age of 12 weeks, I guess. Is like the glucose level is more than 30 millimole per liter. Another animal model I can suggest is the Gotokaki Zaki rat, which is a lean model of type 2 diabetes, and also it depends on the glucose level, and GK rat also develop complications at certain stage. So I think that's all for now. Maybe.
Okay. I mean, you mentioned a few species of rats. So where do you purchase these rat models actually?
Oh, okay. This is a bit complicated. Not complicated, but this one cannot be obtained from our local supplier from Malaysia. Actually, it has to be purchased from outside. Like for I will just talk about based on my experience. Like for the GK rat, it is actually it is originally from Japan. So you have to find a supplier which can actually supply this animal model. Maybe is nearer in Thailand also they have it. But from my experience also, you can purchase the SDT rat, the diabetic tori rat, from Thailand. You can get it from Thailand. So you have for this study you have to actually consider several things like the transportation, the acclimatization period. You have to consider everything before you purchase, and then the age of the rat. I think. Do I answer the question?
Yeah. Okay. Dr. Farah, thank you. I think.
Yeah, it's okay.
I think we only have 5 minutes more, so I think we will conclude. We will end the Q&A session now. So if there's any more question from viewers, you can email the speakers. So they will try their level best to reply through email. We hope that this webinar had shed light in some research work that we are conducting at our institute and would spark interest and could initiate research collaborations with others. Ladies and gentlemen, now we have come to an end of the webinar session. I would like to thank all participants for their support to make this session successful. You may subscribe to our National Institute of Health Malaysia YouTube channel and click for notification whenever there is a new post. Before I conclude, I would like to announce that we will have the next session of IMR-SEAMEO Webinar Series on the 24th June 2022. So do mark your calendars. The theme for the next webinar is Clinical Prevalence of Zika virus infection and its vector distribution. We hope you can join us at the next session. Until then, many thanks from all of us at IMR. Take care and stay safe.